jaundiced goat while it defecates on your leg. Patients with malignant obstruction may report unusually light, clay-colored stools. Why? Compared to other causes of extrahepatic cholestasis, malignancy is more likely to cause complete or near-complete obstruction. The result? Little to no bilirubin reaching the intestines. Normally, bilirubin is metabolized by gut bacteria into urobilinogens, which, once oxidized, are converted into the pigmented molecules urobilin and stercobilin, responsible for the brown color of stool. Without these pigments, the stool appears clay-colored, or acholic. Pale stool is often accompanied by dark urine as a result of high urine bilirubin levels. As mentioned earlier, conjugated bilirubin can be excreted into the urine thanks to its water solubility and relatively small size. Complete biliary obstruction leads to very high levels of both unconjugated and conjugated bilirubin in the serum. As a result, large amounts of conjugated bilirubin spill into the urine, making it appear dark. Ugh, just look away. Classically, malignant obstruction also presents with Courvoisier's sign, a non-tender, palpable gallbladder in a jaundiced patient. Or in this case, a jaundiced rassled goat playfully head-docked at the cowboy's upper right abdominal quadrant. The mechanism? Malignant obstruction produces chronically elevated intraductal pressures. As long as the obstruction is distal to the cystic duct, the pressure backs up all the way to the gallbladder, causing it to become distended. In reality, this sign is present in only a fraction of patients with malignant obstruction. In addition, any prolonged severe obstruction distal to the cystic duct can lead to Courvoisier's sign. That said, its presence does make cancer more likely than an intermittent obstructive process like choledocholithiasis. On ultrasound, malignant obstruction usually produces bile duct dilation behind the site of obstruction, just like other causes of extrahepatic cholestasis. In addition, ultrasound may demonstrate a mass in the pancreas or bile ducts. It's not just stones in cancer. Parasites can obstruct the bile ducts too. The large roundworm, Ascaris lumbricoides, is embodied by the Oscar's lumbricoat truck. Ascaris lumbricoides is a common cause of extrahepatic cholestasis in some developing countries. Adult worms primarily inhabit the small intestines, but can migrate through the papillae into the large bile ducts. Although rare in the United States, this worm affects nearly 1 billion people worldwide. Yep, that's right, billion with a B, and an I, and okay, I think you get it, but a lot of people. Fortunately, most are asymptomatic. Still, a staggering number. The majority of cases are in Asia. So consider ascariasis on your differential in patients with a history of immigration from or travel to this area of the world. The worm is acquired by ingesting water or food contaminated with eggs. Thanks to their large size, these worms are readily apparent on imaging, including abdominal ultrasound. Look for long, linear, parallel structures within the bile ducts, not unlike these large, long pieces of lumber. In general, ascariasis can be confirmed by finding ova on stool microscopy. So we've drawn in some farming equipment that looks microscope-esque, to say the least. In addition, patients may report seeing adult worms in their stool, a sight unlikely to be forgotten. Clonorchis sinensis, a flatworm known as the Chinese liver fluke, can cause both intra- and extrahepatic cholestasis. In particular, adult flukes have a predilection for the small ducts within the left lower lobe of the liver. Just think of this clon orca here, inhabiting the left side of the liver-shaped map. Adult flukes can live in the bile duct for decades. Chronic exposure to large numbers of flukes leads to diffuse bile duct injury, as well as physical obstruction of ducts by adult flukes. Clonorchis is acquired from ingestion of undercooked fish. It's endemic in parts of East Asia, including China. Since symptoms of biliary obstruction primarily occur in patients with chronic, repeated exposure to a large number of flukes, Clonorchis infection should be on your differential if a patient has emigrated from an endemic area. On ultrasound, the flukes may be visible as little echogenic, i.e. bright, spots within the biliary tract. In addition, bile duct dilation and gallbladder distension are common. Again, look at that poop. Clonorchis infection can be confirmed by finding ova on stool microscopy. Next up is primary sclerosing cholangitis, symbolized by that green biliary sclerotic snake. This is a chronic inflammatory disease characterized by fibrosis and stricturing of the bile ducts. In most cases, both the intra- and extrahepatic ducts are affected, so we're talking both intra- and extrahepatic cholestasis, which is why we've placed this dude on the fence of the liver pen. It predominantly affects men, and the majority are diagnosed in their 30s and 40s. Many patients also have ulcerative colitis. Because of this association, a history of ulcerative colitis or classic symptoms, such as bloody diarrhea, should raise your suspicion for PSC. Ultrasound may demonstrate focal bile duct dilations or bile duct wall thickening, but also can be normal. And finally, back inside the liver pen for one more cholestatic disorder, this time affecting only the intrahepatic bile ducts. As a reminder, in the setting of intrahepatic cholestasis, the bile ducts usually appear normal on ultrasound. Primary biliary cholangitis is an autoimmune disease characterized by destruction of intrahepatic bile ducts, eventually leading to intrahepatic cholestasis. About 90% of affected patients are female, and most are diagnosed in their 40s and 50s. The hallmark serologic test for PBC is the presence of antimitochondrial antibodies. They are both sensitive and specific for this diagnosis, so they're present in almost all patients with PBC. A negative test effectively rules out PBC. All right, it's time for our third and final pattern of abnormal laboratory findings: isolated hyperbilirubinemia. This refers to elevated bilirubin in the setting of normal AST, ALT, ALK-Phos, and GGT. No liver injury or cholestasis here. This pattern can present with either unconjugated or conjugated hyperbilirubinemia. Let me show you what I mean. Think of the isolated collared goat as isolated conjugated hyperbilirubinemia. This is a relatively rare finding. It's seen in two autosomal recessive inherited disorders: Dubin-Johnson syndrome and Rotor syndrome, symbolized here by the garbage bin and the rotor windmill. The underlying mechanisms are different. Dubin-Johnson is caused by a defective bilirubin transporter, while Rotor is a result of impaired reuptake of conjugated bilirubin. But the end result is similar: decreased excretion of conjugated bili into the bile ducts. So it builds up in the serum instead. Classic conjugated hyperbilirubinemia. Both disorders present with jaundice, usually starting in the second decade of life. Patients are otherwise asymptomatic, a bit like this young, happy lad, and don't require treatment. In fact, it's not even necessary to distinguish between the two disorders. That's it for isolated conjugated hyperbilirubinemia. In contrast, isolated unconjugated hyperbilirubinemia is far more common. Yep, we've come full circle, back to our first uncollared, unconjugated goat, wreaking havoc. Hemolysis, represented by these splattered tomatoes, is an important cause of isolated unconjugated hyperbilirubinemia. Remember, bilirubin is a breakdown product of heme. In hemolysis, premature destruction of red blood cells leads to increased production of unconjugated bili. In the setting of brisk hemolysis, even a normal liver can't process the unconjugated bilirubin fast enough, so it builds up in the blood. Both intravascular and extravascular hemolysis can increase the unconjugated bili. Disorders may be either inherited or acquired. A few additional labs can determine if hemolysis is to blame. Clinically significant hemolysis presents with anemia. Look for a decreased hemoglobin and hematocrit on a CBC, represented, as always, by that falling H&H abacus. Also, look for laboratory evidence of hemolysis, including an elevated reticulocyte count, as the bone marrow attempts to compensate by increasing RBC production. At Sketchy, reticulocytes, or immature RBCs with large lacy nuclei, are symbolized by large lacy teabags inside of RBC-shaped teacups. Also look for an elevated serum lactate dehydrogenase because of release by hemolyzed RBCs. Also check for a low serum haptoglobin, because haptoglobin binds to free hemoglobin and is rapidly cleared from the blood. Just think of this happy haptoglobin sign broken and low to the ground. In addition, the peripheral smear may display abnormally shaped RBCs, like schistocytes or bite cells, depending on the underlying etiology. Check out our hemolysis sketches for more info on this topic. Isolated unconjugated hyperbilirubinemia can also be drug-induced. Rifampin and probenecid are some of the most common culprits, symbolized by this rifampin rifle and probenecid probe. Both of these drugs increase serum unconjugated bilirubin by impairing hepatic uptake of unconjugated bili from the circulation. This is reenacted by this uncollared goat here denied entry into the liver pen. Gilbert syndrome is another cause of isolated unconjugated hyperbilirubinemia, embodied by old farmer Gil, up to his usual antics and chasing after that uncollared goat. This is a common inherited condition, affecting 3 to 7% of Western populations and generally first presents in adolescence. This autosomal recessive disorder is characterized by reduced activity of UDP glucuronylsyltransferase, the enzyme responsible for conjugating bilirubin within the hepatocyte. The result is mild impairment in conjugation of bilirubin. He just can't get that collar on the goat. Gilbert syndrome presents with intermittent episodes of jaundice and mild unconjugated hyperbilirubinemia. Episodes can be triggered by events such as illness, fasting, physical exertion, stress, or menses, which is why we've emphasized the trigger at his side. Patients are asymptomatic between episodes. An otherwise healthy adolescent or adult with mild unconjugated hyperbilirubinemia, no evidence of hemolysis, and normal liver tests can be presumed to have Gilbert syndrome without the need for genetic testing. The condition is benign and doesn't require treatment.